Hello everyone, hope you are doing fine. Today the video is regarding kidney biopsy report interpretation. The video is more for medicine second year or third year residents who have difficulty in interpreting the kidney biopsy reports, and a few might be having doubts why to do the biopsy. I will try to clear a clarity in this video. Why biopsy required? Biopsy is usually required to diagnose any particular disease if it is having any impact on the outcome. In AKI, in unexplained renal dysfunction, biopsy is nothing but a piece of kidney tissue is being taken and histopathologically it is being analyzed. If we take the question into when to consider biopsy, first to make a diagnosis. Suppose if you are not able to make the diagnosis with other non-invasive markers, and it should have an impact on treatment. It is not that you make a diagnosis of diabetic nephropathy and the treatment is going to be the same. During that point of time, biopsy might not require. It should have a clear-cut impact on the treatment. It should alter the treatment plan. There should be some differential. Then only you have to consider a biopsy. And biopsy usually help to ascertain the prognosis, depends on the amount of fibrosis. A best example is, for example, a patient had a pre-renal AKI. Because of severe volume loss, the patient urea creatinine went to 4 and gradually it is recovering. Do you have to proceed with the kidney biopsy? No. There is no much benefit, but the risk is there because it is a invasive procedure. Kidney tissue is being removed. Risk is more than benefit. So in these cases, you might not require a kidney biopsy because you can make the diagnosis without biopsy also. For example, a 25-year-old male with unexplained renal dysfunction, kidney size is normal. All other non-invasive markers are negative. You want to know the basic disease, then there might be a role of biopsy. And any autoimmune disease patient, we want to decide on the treatment with immunosuppression, how long to give, and the patient themselves might be having the question, sir, how long I should take, whether my kidney will recover or not. During those kind of situation where duration of the treatment will be decided by the biopsy report, how long the treatment to be given will be decided by the biopsy report. These are the clinical situations where biopsy is really helpful. Without knowing this, even in a simple case of diabetic nephropathy, many residents will be running behind the kidney biopsy rather than trying to make the diagnosis. Even if I ask in a diabetic patient why you want to do the biopsy, if the diagnosis of diabetic nephropathy is clear, they might not be knowing. So that is why what treatment impact the biopsy report is going to give, you have to be very clear. Not all renal dysfunction require biopsy. Only few unexplained renal dysfunctions require biopsy. So as a medicine resident, try to make more of diagnosis rather than going behind the biopsy report. Then what is biopsy? Biopsy is nothing but taking out a piece of kidney tissue from the kidney, either of the kidney. You can take from the right or you can take from the left. Usually it is taken from the lower pole and is being analyzed under the microscope. So this is the kidney. If I magnify it, inside it there will be lot of nephrons. Like this, there will be nephrons. The nephron, you will be having glomeruli, tubule, vessels, and the interstitium. So I will take a biopsy from a particular point of kidney where I am supposed to see the 4 important components. I have to see how is the glomeruli, I have to see how is the interstitium, I have to see how is the vessels and also tubules. If I take the glomeruli, inside the glomeruli also there are lot of component. This is the blood vessel, afferent arteriole, in between mesangium is there. The filtration podocytes are here, capillary loop, blood vessel lining, the parietal epithelium. This is a normal anatomy. This is called the entire glomeruli. This is a normal anatomy. This also we have to see any abnormality is there or not. Sometimes this entire structure is called as the glomerular tuft. This is entire structure is called the glomerular tuft. So once we are obtaining the biopsy, we have taken a small piece of tissue which is 1 centimeter or 1.5 centimeter using the biopsy gun. The procedure I am not describing here. Just we have taken out the biopsy from the kidney. That biopsy tissue has been taken out. And what next? We have to see it under three microscopes. One is light microscope. Another one is immunofluorescence microscope. Immunofluorescence microscope is nothing. You are going to see the immune deposits are there or not. It is basically for the checking the immunoglobulin or the immune related items are deposited or not. Since you are directly seeing with the help of fluorescent material that you are adding, that is called direct immunofluorescence. And third one is the electron microscopy, which is nothing but the ultrastructural visualization of the minute structure. So how much magnification this light microscope will give? Light microscope, you can see the kidney at 40 times magnification, 100 times magnification, and 400 times magnification. Usually oil immersion for kidney biopsy we won't use. We'll be looking at scanner view, low power view, and a high power view. So up to 400 times magnification you can see the kidney tissue. This is regarding the light microscopy. Light microscopy basically for the structural anatomy. What are all the problem you can make out at the 400 level magnification. Immunofluorescence is basically for the immune globulin deposits, immune globulin complement, or any kind of immune mediated materials are there or not, we can visualize through the immunofluorescence. Electron microscopy for the ultrastructural details, because podocytes are very small. You can't see at 400 times magnification. You need more magnification. For example, 10,000 times magnification might be required to look at the podocytes. So that is where the electron microscope come into picture. So three microscope analysis we have to do. So this is the kidney from where we usually take the sample from the lower pole. Through the biopsy gun, we will be taking out the tissue and sending for the analysis. So in the light microscopy, this is how the glomeruli appear. 4 slides back, I have shown you the diagrammatic representation of the glomeruli, and look at the actual image after staining. You can see it is looking some rose colored, some blue colored cells are there. These are capillary vessel. Some kind of colors have been applied, then it is appearing like this. Shall we use only one color? No, in light microscopy there are multiple staining materials are used. Why? Because some this capillary endothelium, basement membrane, podocytes, mesangium, so many structures are there. The composition of the each cell, for example, collagen, glycogen, even white blood cells. There are various kind of cells are there, so each will have affinity for different kind of stains. So that is why multiple color stains are used. So in light microscope, we'll be using the routine eosin and hematoxylin stain, methenamine silver stain, Mason trichome stain, periodic acid chef, Congo red. These are all the commonly used stains for light microscopy. These individual stain, which component of the cell it stains better, might be of DM topic that I have already discussed in a video. At the medicine residency level, just remember multiple stains are used to identify the structures in a better way. And two important terminology you should know in biopsy. In biopsy report, you might be seeing the terminology called IFTA, which is called as interstitial fibrosis and tubular atrophy. As you see in the glomeruli, the entire tubules and the nephron, these are the interstitium. Interstitium. IFTA will tell how much of the percentage of the sampled specimen went into fibrosis. That means these are not required. Suppose if that shows 90% in the biopsy sample, if it has 90%, that is totally fibrous. There is no point in giving a treatment focusing on the recovery. So that is why IFTA is a very important component in the biopsy report. And as I told, the sample will be taken from a particular point of the kidney in the lower pole. This is a representational glomeruli. How many glomeruli are there in the particular sample will also be mentioned in the report. We'll see one sample report also right now. So few other terminology. So we have seen the representational image of the glomeruli. Suppose if there are polymer inflammatory cells comes inside the capillary, what I will say? Polymorphs are present inside the capillaries, but in biopsy they won't say like that. They will say as endocapillary proliferation or endocapillary hypercellularity. This is one terminology. The glomerular tuft, I told you the entire structure is the glomerular tuft, I have told you. Another one is, suppose if there is a break in the capillary loop and the white blood cells or the inflammatory cells goes outside and deposit there, this is called as extracapillary proliferation. Because of the cytokine and the interleukin, more cells will be attracted, more fibrin will be deposited. So this gives a crescent shaped or moon shaped appearance. This is called as crescents. Parietal epithelial cells might get proliferate along with the inflammatory cells to form the crescent. These are few terminology you should be aware of. So we have seen the glomerular tuft. I have told you regarding the endocapillary hypercellularity or endocapillary proliferation. Crescent is nothing but the proliferation in the parietal epithelial cells because of the damage in the capillary inflammatory cells intrude there. Why it is important? It basically indicates there is some kind of ongoing inflammation, probably autoimmune etiology. The polymorphonuclear cells are going there. So these are the terminologies which might be confusing at the beginning level. So once you know this terminology, now you are all set to interpret the biopsy report. We'll see one sample biopsy report today. So we have seen what is kidney biopsy, when it is required, what are the three microscopes that we use, and importance of each microscope. And in the light microscopy, why multiple stains are used, that also we have seen. I hope now you will be in a position to interpret the biopsy report. Let's see one biopsy report. So this is a sample biopsy report. So here the basic detail, patient name, age, lab number, referred by, all the basic details are given. This image is of no use, very difficult to interpret, you can't interpret. First we will go line by line. What they have written, renal pathology report. First specimen. The specimen is the kidney biopsy panel. What is the history? Patient is a approximately 48-year-old male who had hypertension, generalized weakness, loss of appetite, and his serum creatinine was 6. C3 normal, ANAs, ANCA, dsDNA all are negative. He is excreting around 6 gram of protein per day. So what is the why this patient have been decided for biopsy? The details are very clear. Patient is 48-year-old, hypertension, presented with creatinine 6. No other clues there. We could not find why the patient is excreting so much amount of protein. So for what disease I will treat? He is not diabetic. There is no clear cut any other infective history. The patient is having renal dysfunction. So I have to do the biopsy to find what disease the patient is being affected with. Then only I can plan the treatment or explain the prognosis. So they have taken the kidney biopsy with the help of the biopsy gun. Two cores the pathologist have received. One is 0.7 centimeter, another one is 0.7 centimeter. DIF is direct immunofluorescence studies. Formalin, when this is nothing but a preservative. You take the sample in the hospital and send it to the pathology lab. Till the time that tissue should not be damaged. For that they use preservative. To check in the light microscope, you need formalin. To check in the immunofluorescence, you can use even a normal saline. Okay. These are all the basic detail we have got. In the first section, we have got the patient detail. In the second session, they have mentioned what is the specimens gross dimensions they have mentioned. Why they are mentioning the gross dimension? So that we will get the idea how much core they have got. Since it's a representational tissue of the entire kidney, we should know how much representation the pathologist have got. So next we will go to the microscopy. This is a continuation of the previous page only. See what they have mentioned, multiple sections have been stained with eosin and hematoxin, periodic acid chip, silver methenamine, mason trichome and congorate. They have used 5 stains to check the gross section. They have made 5 slices. Each slide will be each slice will be stained with a separate stain, and 5 stains is seen separately. So what they are saying, cortical parenchyma containing 11 glomeruli. So how much they are saying? 11 glomeruli, out of which 7 is globally sclerosed. Sclerosed means you could not make out anything. It is totally sclerosis ogia. So it is very difficult to interpret the gross anatomical structure. So out of 11, 7 are gone. 3 glomeruli reveal segmental tuft sclerosis. Now you will understand what's tuft. They have told the entire glomerular tuft going to for a sclerosis. What else they have made out? Focal extracapillary proliferation. Extracapillary means outside the glomerular capillary, there are presence of inflammatory cells. So this is the terminology they use. So that is why the medicine resident who doesn't get exposure to these kind of biopsy report, they will get confused what the pathologists want to say. So there is extracapillary proliferation and the crescent formation. Pseudo crescent I will explain in the subsequent videos of biopsy. So crescent, I told you there is a formation of a moon shaped structure outside and some oversclerosed segments. Viable areas show mild increase in the mesangial matrix. As I seen in the mesangium, the matrix got expanded. There is no evidence of endocapillary hypercellularity. Basically, that means there is no much inflammatory cells within the capillaries. Condylophilic deposits are intracapillary thrombi in the viscularized glomeruli. So there is no evidence of endocapillary hypercellularity, duct necrosis, condylophilic deposits, intracapillary thrombi. These are not seen. Necrosis is more dangerous than sclerosis because necrosis means actively the tissue is getting necrosed. Acute tubular necrosis, acute cortical necrosis. So what the pathologists want to mention, there is no area necrosis out there. Then comes the look at here. Tubular atrophy, interstitial fibrosis involve 50% of the sampled cortex. That means 50% is already gone. So it won't be recoverable. But in the representational sample that we got, So this is also called as IFTA. IFTA is 50%. That means another 50% is recoverable. So your treatment have to be bit aggressive. Then some non-specific finding they will mention about the tubules, scattered, insipid, hyaline cast, sloughed epithelial cells, occasional cellular debris containing cast, and granular cells are seen in the tubular lumina. Basically, they are mentioning about the tubules here. Multifocal chronic interstitial inflammation is noted. So in the interstitium, there is a chronic inflammation is there. What about the vessel? Artery shows circumferential and medial thickening. This is continued in the next page. Occasional arterioles exhibit vessel wall necrosis and luminal occlusion. So what we have seen, glomeruli we have seen the finding, tubule we came to know, interstitium we know there is inflammation, artery we know there is some kind of occlusion is there, which they have mentioned as thrombotic microangiopathy. Okay, we have seen in the light microscopy, this is the structure. But what could be the etiology? Till now, the etiology is not clear. There is nowhere there is a clue. We have seen the histopathology, 400 magnification. We have saw what is the damage going on in the kidney. But did we got any clue for the etiology? Till now, no. So now we are going to the immunofluorescence microscopy. Why it is mentioned as DIF, direct immunofluorescence? Some report mention only as immunofluorescence, some mentions as indirect immunofluorescence. But for kidney biopsy, mostly it is direct immunofluorescence. You put a fluorescent binding material to the tissue and find what is the material which is getting binded. It is simple. Tissue for DF contains renal cortical parenchyma. Here also number of glomeruli are mentioned. 3 glomeruli. The following immunostaining pattern is observed. They have put IgA showing 3 plus IgA fluorescent material is binding to IgA. 3 plus. Where it is binding? It is binding in the mesangial area. This granular, no need to focus right now. IgG is not at all binding, which is negative. IgM is also not at all binding. C3 is 1 plus. Here in this, which is more significant, 3 plus means significant. C1q is also not binding. Light chain also very minimally binding. So what is the most important catch here? We got the interpretation that IgA is 3 plus binding. So only IgA is binding. That means it is predominantly IgA deposit. So whenever it is IgA deposit, what it could be? And already the crescents were there, crescent. That means inflammatory cells which is in the extracapillary space. So in this patient who presented with this history, we have seen light microscopy wise 11 glomeruli were there. We came to know there are some inflammatory cells within the glomeruli. Interstitium is inflamed, artery is thrombosed, and fibrosis about 50%. That means 50% recoverable kidney is there. Immunofluorescence shows only IgA. That means it is a case of IgA nephropathy. Do I want to proceed with electron microscopy? No, at this point of time, I am clear with the diagnosis. I know how much recoverable kidney is there. Which disease I have to treat? It is IgA nephropathy. So, with the help of light microscopy and immunofluorescence alone, I have made the diagnosis. Is electron microscopy compulsory? No. If I could not make the diagnosis of immunofluorescence also, probably I might want to look at the podocytes. There are certain diseases which can be diagnosed only by electron microscopy. For example, minimal change disease. The name itself says minimal change. You won't get any change in the light microscopy or immunofluorescence. Only the finding will be in the electron microscopy, 10,000 times the magnification. So at least for this case, I won't require electron microscopy. I have made the diagnosis. Let us see what in given in the impression. Look at the impression. See what the diagnosis I have given is. It is IgA nephropathy featuring this. You leave it. You will get confused. Nothing but glomerular sclerosis are there in 7 out of 11 glomeruli. So IgA nephropathy featuring, they want to bring the important information here. As of now, first point you take it is IgA nephropathy. Multifocal chronic interstitial inflammation is seen. IFTAS 50%. Arterial sclerosis with the thrombotic occlusion is seen in the particular part. So now my diagnosis is very clear. So what is the diagnosis? It is IgA nephropathy with the crescent with IFTA 50 percentage. This is how the diagnoses are being made with the help of biopsy report. This is one sample biopsy. If in future you come across any biopsy report, try to interpret in this way. Don't directly jump to the impression. Try to make the diagnosis by reading the light microscopy. What is the importance of the number of glomeruli? Many a time in the gross specimen they might have mentioned no glomeruli seen. If there is no glomeruli, you can't interpret the report. This is as simple. So that is why starting from the first line, each detail is very important. And also you should be aware why the diagnosis is not made with non-invasive markers. So now you are all set to read the biopsy report. I have many multiple different disease ka biopsy sample reports. Today I have discussed the biopsy report of IgA nephropathy. Probably soon, over a period of time, I will try to discuss the biopsy report one by one. For example, of a minimal change disease, of FSGS, of multiple myeloma. Till then, goodbye.